Thank you. Thanks for this opportunity to present. I'm Simon Baldwin. I'm a PhD student at University of Birmingham. It's a statistics PhD with Dr. Alice Sitch and Professors Yemisi Takwangi and Jonathan J. Deeks. And the team, the Biostatistics Evidence Synthesis Test Evaluation and Modelling team, are very well regarded in evaluating tests. John has been doing this for a number of years. I'm very grateful for him taking me on to do a PhD. So I'm going to talk a little bit today about opportunities and challenges in using routine secondary care data sources to evaluate biomarkers. And I'll start at the beginning, really. So what is a biomarker? Well, a biomarker is a biological measurement produced by a test. And this could be a laboratory test, it could be a physiological test, or it could be an imaging test. So probably one that we all recognize is blood pressure, and it's commonly used to diagnose hypertension. It's done in GP practices. It's also done in the home now as well by home use devices. And biomarkers are essential in healthcare, given their role in diagnosing and prognosing patients, but also for developing and evaluating monitoring strategies. They inform changes in patient management, such as treatments and interventions, but also biomarkers are commonplace as predictors in model development. And actually, we maybe don't think enough about the quality or the variability or the accuracy of biomarkers before they get put in as predictors in model development. So this is hopefully where this PhD is going to help add to the body of evidence around accuracy of biomarkers. So why would we want to evaluate them? Well, biomarkers can actually be of really great benefit to patients. A biomarker that gives off a true positive might prompt patient management to occur more quickly, and a true negative might offer some reassurance for patients that they don't have a disease. But in the same way, biomarkers can also lead to patient harm, and false negatives might result in necessary treatments or interventions being delayed. False positives might result in negative psychosocial consequences. And in the early stages of biomarker development, a test needs to be evaluated for its reliability. So there's another term there, reliability. What do we mean by that? Well, to evaluate the reliability of a test, we're looking to do that with respect to the clinical information it's able to provide. And by this, we're thinking about combining how reproducible is the test, but also how is the test able to detect fluctuations in health state over time. And as a BRC funded PhD student, this early stage evaluation of biomarker reliability is a key aim of the funding stream. So the best way and the traditional way to do this is through biological variability studies. And these studies aim to evaluate the reliability of tests by estimating and comparing the components of variability that you see in biomarker measurements. These estimates of variability are crucial to inform the role of tests in healthcare, such as in the development and ongoing evaluation of how well or how not well a monitoring strategy is working. And in an optimal biological variability study, you'd have individuals or patients, and they would attend monitoring visits, say to outpatient clinics to time points. And within each time point, you would ideally see repeated measures taken on patients multiple times, so that you have a study of this design. So on the leftmost panel, you've got your two patients, A and B. They have then on the middle panel attended visits, one occurring at time 0 and another one occurring 6 months later. And actually within each visit, they've then had 2 blood pressure measurements taken. So, so what might have happened in, say, patient A's second visit. Perhaps they were running late to the clinic appointment, so they've ran from the bus, they've turned up at clinic, they're out of breath, and they have their blood pressure taken, and it's high. It tips over the 120 mark. They then have the opportunity just to sit down, chat to the doctor, relax a bit, and 5 minutes later, their blood pressure has all of a sudden gone down. What we're seeing there is biological change there, but it's short term. It's what we regard as being like short term measurement error. So the first measurement was not taken in the correct setting. The second measurement was much closer to the setting we'd like the measurement to be taken in. And I've just touched on that a little bit, but the components of variability that you see in repeated measure studies of this type of design, you'll have variability attributable to differences between patients, and then differences between time points but within the same patient. And we refer to this as being the signal in a process. And then you'll also have variability attributable to differences within the same time point and within the same subject, which is referred to as the noise, or maybe a more common term for that is measurement error. So that's where we're talking about that patient who has had an elevated blood pressure measurement, but has then waited for 5 minutes and their blood pressure has reduced to a more stable level. Yes, so the measurement error signifies the variability that may occur in multiple biomarker measurements on the same subject taken at almost the same time. So in laboratory biomarkers, what we're talking about here is really split sample or analytical variability. But in physiological biomarkers like blood pressure, this is going to contain some short-term biological variability as well. So I've now mapped those variability components onto the previous diagram, the previous study design. So in the red there on the leftmost panel, you've got the variability between subjects, which is represented by an alpha term there. So I've introduced some hopefully not too intimidating algebra here. In the middle panel, you have got the variability between time points within subjects. That's represented by the beta term. And then on the leftmost panel, we've got the variability within time points within subjects, which is the omega term. And just to mention that a lot of work on this has been done by Dr. Alice Sitch and soon to be Dr. Kostas Triposkiadis. They've done a lot of work looking at conventional biological variability studies. And so using those to evaluate, to go back to our reliability, we need to understand the estimated level of measurement error and the estimated level of true change between time points. And we ideally want to know how well a test distinguishes the signal from the noise. So this is where my PhD comes in. So biological variabilities studies in practice, they're not always feasible. Prospective studies, they can be expensive to run. They can be really hard to get patients recruited. And then not just that, but getting multiple biomarker measurements on those patients is even more difficult. And data collection in these kind of studies occurs under controlled conditions, usually over short periods with small sample sizes. Ideally, what we'd like is a situation where the data we're looking at is taken on patients in whom the test is actually being used in clinical practice, and that's maybe where the routine data is going to come in a minute. And there are also problems in biological variability studies in terms of what we do when the necessary data required for methods that are mainly used in that kind of domain. What do we do when the necessary data is missing? So this might be that we don't have the multiple measurements taken within the same visit, or it might be that we have measurements taken at irregular time points. We may have total numbers of measurements per patient that are different, such that two no patients share the same number of visits recorded at the same time points. This kind of knocks out a lot of the common methods that are normally done in biological variability studies, such as twofold ANOVA or like repeated measures ANOVA, because we have all that missing data. So this is maybe where we have an opportunity here with the right methods to use routine data. I maybe don't need to tell this audience this, but routine databases they're a convenient source of repeated measures data. They're compiled in real time and they're recorded over extended periods where long-term changes in patients' health are captured. So these are really good things that are missing in prospective data collected as for biological variability studies. But we will have issues in routine data with the necessary data being missing. There are some logistical complications to consider in getting access to routine data, and there's also missing context sometimes in which testing is performed. Routine data obviously captures a lot of what's going on in a patient visit or episode or spell in hospital, but there are some bits of the context that might be handwritten that might only be known to the doctor or consultants seeing the patient. So there is this possibility of repeated measures being informatively observed. So this is going to be split into 3 work streams. So work stream 1 has been coming up with the right methods to analyze variability sources in routine data. Lots of us probably aware of the linear mixed effects modeling framework. It was proposed by Laird and Ware, and it does facilitate this ability to estimate measurement error if we had those multiple measurements taken at a short time period for the same patients. And it quite easily handles this issue with irregular time points as well. Probably the most commonly used version is the random intercept and slope model. It's modeling the changes from the baseline, and it's attributing the variability to differences between and within subjects and time points. So returning back to the algebra I introduced earlier, this is our change from baseline model. The alpha term represents the baseline measurement, but not just the baseline, but the true unobserved bit of it. So the bit that's the truth, but is being obscured by measurement error. So we've split the measurement error out from the truth. We've also got the beta term there as well, which is the change from the baseline. So this might be that patients had a baseline measurement and then they've come back 6 months later and their blood pressure's gone up by 10 mmHg. That would be what that beta term is there, the 10 mmHg in change there from the baseline. But importantly, we've then got the measurement error. So this is the bit that says, well, actually, how accurate is the measurement that we're actually taking on that patient at that time? So that's modeled as a separate term from the 2 true bits there. And this linear mixed model approach, it assumes that each patient will effectively have their own linear regression. There'll be a average linear regression, and the difference from that main linear regression will vary between the subjects. So you'll have variability of the observed values around the patient fitted values, and then you'll have variability of the fitted patient intercepts around the average intercept, and then variability of the fitted patient slopes around the average slope. So that's where we're getting estimates for the 3 components of variability from the linear mixed model. But we've been more interested in a slightly more novel approach. It's maybe a little bit more pragmatic than linear mixed modeling, and it's called a variogram method. And the idea is that you take the measurements from baseline and then you pair them up to each of the follow-up measurements. So we've got a baseline measurement here of 0, and then we've got 5 follow-up measurements, 1, 2, 3, 4, 5, and each of them are paired up. When you then take the variance of the differences between the pairings, you're left with the variability of the beta term, which is our true change variability, plus 2 lots of measurement error because we're comparing 2 pairwise points, and each one of them will contain some measurement error. And so comparing the approaches, we've got the linear mixed model on the right there, and just down to how the model derives the variance formula. It imposes this quadratic form on the signal, or the true within individual variance, that then increases quadratically over time. It doesn't look too bad over that period of 5 years, but you can imagine if we were looking at long-term data, such as up to 20 years, that quadratic increase would really go some probably in those additional 15 years. So for short time periods, maybe it works well. For long-term monitoring, we didn't feel it was quite as good as maybe this variogram method might be. And yeah, so it takes the direct estimates and it produces this hopefully better fitting form of the signal over time. We've obviously, in this example, there's a linear regression there, but it could be non-linear if that was how the direct estimates were increasing. So those were the first 2 approaches we looked at, but then something we haven't talked about here is the correlation between repeated measures. And when measurements are correlated, the covariance between terms make inferences on the variability components a little bit more ambiguous. So we've still got our 3 terms there, our var alphas, betas, and omegas, but we've also got this covariance term in the middle. So an alternative is a piece of work that's been done by Peter Diggle, and it's this semi-variogram approach, which is very similar to fitting a linear mixed model, but with serially correlated residuals. And instead now what we're looking at, instead of an unobserved baseline, we're looking at an unobserved mean, an unobserved change from mean, and then measurement error is still there as well. And the semi-variogram method, instead of just looking at the pairs from baseline, we're looking at all of the pairs from measurements 0 to the pairwise follow-ups, but also then 1 to the pairwise consecutive follow-ups, 2, 3, 4, and so on. And this time, the variance of those differences is equal to, we've got our variance of the betas again, and we've got our variance of the omegas, but we've also got this covariance term here as well. And the semi-variogram method assumes that that covariance is going to decrease over time as measurements that are further removed in time become less similar to each other, to a point between 4 and 5 on this diagram, where measurements are no longer correlated, and this graph flattens out to give us the signal estimate and the noise estimate. So we've got the same estimates that we had from the last 2 models, but we have now accounted for the fact that measurements are going to be correlated with each other. And so we did a quick case study on this, which was looking at systolic blood pressure measurements in children. And this was a good case study because repeat measurement of systolic blood pressure in children we felt was never really going to show any signal, because there aren't significant changes in blood pressure when patients are children. It's only when you develop things like, hypertension as you get older, that you'll then start maybe seeing a bigger signal in blood pressure measurement changes than you would in stable child patients. So we use the semi-variogram method here, and what we found was actually the signal estimate, so this is a variance estimate, was only 15 mmHg squared. The noise estimate, which is our measurement error, outweighed it significantly by about 4 times. And so we've got there the signal to noise proportion at the bottom. So the noise accounted for about 80% of the variability. And how could we use this? Well, we've got so we could use the coefficient of variation, but perhaps what's maybe more useful in a clinical context is that actually this measurement error, this 7.83% coefficient of variation of measurement error, would have estimated that a change in systolic blood pressure of more than 22 mmHg would have been necessary to be 95% confident that true change was being detected over measurement error. And this is something that hopefully like clinicians can use in clinic to say, we've had this change in measurement from one time point to the next, but actually how do I know that what we're seeing there is true change, or is it just more likely to be measurement error? So work stream 2 was addressing the challenges of actually applying this to some routine data now that we've done this on a case study and looked at the methodology. We're lucky at University Hospitals Birmingham to have 2 HDR UK hubs, Pioneer and Insight, and my application for data has mainly been through Insight. Again, maybe I don't need to go into too much detail here, but it's a pathway for accessing routine data on the 80,000 ophthalmology patients served at UHB. It has a vast set of data there. It has a rigorous approvals process, which goes through a patient, public and expert data trust advisory board. So we've been through all that. And my project, just to get to this, is going to be looking at estimating the components of variability in retinal thickness parameters to evaluate OCT image segmentation. So what we've got there on the left is a patient having an OCT done in the clinic. They've then had their scan result there, and that has been sliced and segmented by the algorithm used. So you can see the red lines there segmenting the RNFL layer there. And it maps the thickness onto this chart here and produces a set of thickness classification metrics in the left there. And we'd like to think this segmentation algorithm's like always reliable, but this isn't always the case. So we've got a patient here, they've got prominent optic disc swelling, and actually the algorithm has drawn the RNFL layer line above where it actually sits there, and also above where it finishes along the bottom there. So this is why we feel it's going to be a useful exercise, hopefully, to ophthalmology clinics to evaluate how reliable, what are these sources of variability going on in this OCT image segmentation process, particularly in those classification metrics there. And so just to quickly end on the final work stream, this is the work stream that's coming up. We've now got these peripapillary classification metrics. They've been extracted directly from the OCT scanners. The logistics for access have been signed off. We're going to be looking at analysing data of 500 patients with about 5,000 scans. They've got ocular hypertension and idiopathic intracranial hypertension with up to 10 years of follow-up. And it's going to be the final empirical study of my PhD. I'm going to apply the methods to estimate the measurement error, but we're also going to work with UHB clinicians to maybe further investigate the context in which some of this testing was performed on the patients, and PhD timeline submission hopefully within the next 15 to 18 months. Just a quick set of thank yous to Alistair Denniston and Susan Mollen, who've helped, and the members of the UHB Insight team to get this data over the line. Rosie Boudel here in our department, and the BRC for the funding of my PhD. And I'm happy to take a few questions with the time we've got left. Thank you.